Hello and welcome to part 2 of the Medication Administration lecture, which is chapter 25 in your textbook. So it's important to note that nurses are actually legally accountable for medications that they administer, and this accountability comes from facility policies, procedures, as well as our scope of standards of practice, which the American Nurses Association has established. So any questions regarding the purpose, the dose, the route, time abbreviations, laboratory values, potential interactions, allergies? If there are any questions about any of that, those things should always be resolved with the provider or the pharmacy. And that doesn't really matter how big or how small the issue is, but if there's any question about what you're about to give the patient, you need to make sure and ask the right questions and ask the right resources. There will be emergency situations where a verbal order from a healthcare provider may be given to a nurse or a pharmacist, but the order must be put in writing as soon as possible. And in most settings, student nurses are not allowed to transcribe written orders or accept verbal orders. So the order must be clearly written or entered correctly into an electronic system. Clinical judgment is needed by the nurse to evaluate whether the medication, the amount prescribed, and the route are safe for the patient. The nurse should clarify these orders with the prescriber that are difficult to read and do not contain all of the critical information needed for safe administration, or contain non-approved or unfamiliar abbreviations. There is a list that is out by the Institution of Safe Medication Practices and the AHRQ and a couple of the other agencies that state what some of the abbreviations that can no longer be used. In addition, I would say that a lot of the orders in this particular time, day, and age are typically done electronically. So they are written by the provider in the computer, and once they are verified by a nurse, it gets transcribed typically into the medication administration record, which we talked about earlier. So nurses just need to make sure and clarify any of those orders with the prescriber if there are any questions whatsoever. You have a legal and an ethical obligation to do that. So according to the Institute of Medication, or excuse me, according to the Institute of Medicine, medication errors injure about approximately 1.5 million Americans each year and kill an estimated 7,000 persons. The financial costs for this are very high. Among the hospitalized patients alone, treatment of drugs related to injuries costs about $13.5 billion in lost productivity, wages, and additional expenses. The medication errors may be related to professional practice, healthcare products, procedures, and systems, including prescribing, order communication, product labeling, packaging, and nomenclature, compounding, dispensing, distribution, administration, education, monitoring, and use. There are many steps in the process of medication administration, and a mistake can occur basically in any one of these steps. Fortunately, mistakes can be caught at any of the pre-administration steps, and it's a multidisciplinary collaboration for medication administration that helps safeguard against errors. Because the nurse is typically the last person in the sequence, which is in the administering phase, medications in a healthcare facility, the nurse is the patient's last line of defense. So we are basically their last safety net. In the administration phase is the first part where the drug and that patient interact, okay? So once we give the medication to somebody, it's too late. So we're going to talk a little bit about the medication use process so that you can kind of understand where the safety nets lie And then we'll also talk about some of the things that end up resulting in a medication error. And it's important to note that a medication error is preventable. So that's kind of the key takeaway of this slide, is that medication errors are preventable, and we can stop that error from occurring anywhere in the medication use process. So this is a kind of a rundown of the medication use system. So we have all the way back to, and some people don't think about this, the selection and procuring of medications. So how do these medications get into the hospital? Well, somebody has to put in an order for it, and they need to come, and we need to assume that the medications that we are procuring are medications that we need. Prescribing, that is typically a primary care provider function or a nurse practitioner that's licensed to do so. And then there's preparing and dispensing, which that is a pharmacist function. Okay, we nurses are not allowed to compound medications, meaning you shouldn't be mixing anything into a medication. Now, as far as dilution and those things for like antibiotics, that is fine. You're only putting normal saline or sterile water into the powder and mixing it. But as far as taking a needle and putting something inside of an IV bag or anything like that, that is a no-no. Okay, and then we get to the administering phase, which is, like I had mentioned earlier, we are kind of the last defense, because typically we are the ones that have the medication in our hand. So unfortunately, since we are the ones doing the action of administering that medication, we are the last safety check before that patient and that drug interface with each other for the first time. And then there's monitoring, which we do typically no matter what after a medication. If you give something, you need to go in there and you need to monitor their vital signs. And if you gave them something for pain, we need to monitor their pain level and see if that drug is doing what we intended it to do, to keep our patients comfortable in that particular example. Now, this is you will hear this especially quite a bit in the medication administration safety realm. I have published probably, I think, around 11 articles on medication safety, and did a pretty big study in 2005 that was kind of touched on a lot of this, but it focused on the perioperative arena, or the continuum of care. And it was pretty amazing to find out that not only were we making errors, not only in the operating room, but this has to do with pre-op, same-day surgery, and the like, but the medications that we give in critical care areas are also very dangerous. So what does that mean? Well, that means that if all of these holes line up in this Swiss cheese and we don't do what we're supposed to do in terms of the appropriate prescribing, transcribing, dispensing, and administering and monitoring of medications, that's how an error can happen. And that's just latent failure modeling by Reason. James Reason was his name, and he kind of came up with this. And if you think about it, if all the stars line up appropriately, that error can actually make it to the patient and do little to no harm, or can kill them. So some errors cause harm to the patient directly. An example of that's like giving an excessive dose of medication. Others fail to treat the patient's illness, which is giving too little medication. So other errors include giving the wrong drug, giving a medication to the wrong patient, or using the wrong route. And the human factors, okay, we realize that to err is human, and that can happen. And human factors include the knowledge or the performance deficits administering a drug intravenously, for example, rather than giving it intramuscular. So actions in the event of a medication error, and this is important, include immediate and ongoing assessment. Okay, if you make an error, that's not the time to be quiet or try to cover it up. Okay, you just need to own up to it, own it, and do the proper reporting that needs to be done, which can include notification of the healthcare provider, initiation of the interventions as prescribed to offset any adverse effect, and the appropriate documentation related to the event. So error reporting is a very essential component of patient safety and should be completed as soon as the patient is assessed and stable. So if you give an appropriate dose of a medication, okay, again, this comes back to patient-centered care, where the first thing I'm gonna do is make sure and check the patient and monitor them and make sure that they are safe. And most facilities have specific guidelines for medication error reporting, and some of them there are electronic. And there are places that will do, they also have patient safety committees that will do root cause analysis on some of these medications and find out what the root of the problem is. Barcodes are nice, and they verify that the patient and the drug match and that adverse interactions are unlikely. But I want you to also remember that computers and barcodes and scanning are only as good as the information that we put into them as humans. So the Institute for Safe Medication Practices has compiled a list of error-prone abbreviations. I had mentioned that earlier. And it includes some of the symbols and dose designations that are to be avoided to decrease errors. The safe use of abbreviations is important in preventing medication errors. If you interpret a wrong abbreviation, or maybe you can't read BID versus QID, that can make a big difference. 2 times a day versus 4 times a day. So that's just an example. And as part of the National Patient Safety Goals, which you'll hear a lot about, which was developed by the Joint Commission, which is a concentrated emphasis is placed on the prevention of medication errors. And out of this effort came the Joint Commission do not use a list of abbreviations that were identified as contributing factors to medication errors after compiling all the data and analyzing it. The list of these abbreviations is included in Chapter 10 of your textbook under the Documentation, Electronic Health Records, and Reporting. So the nurse has to understand all 3 types of measurement systems to accurately administer the prescribed medications. In particular, a nurse may need to convert the order's dose to what is dispensed by the pharmacy. So the minimum is followed in increasing order by the dram, the ounce, pint, quart, and gallon. The weight in apothecary system is based on 1 grain of wheat, which is abbreviated as a small gr period. The apothecary system is no longer used on any drug labels. Occasionally the nurse may find a prescription that's written in terms of a fluid ounce or grains, but it's pretty rare. The nurse needs to convert these to a metric system. So the household system is the most inaccurate of the 3 systems. The drop is abbreviated as small gg or GTT period. Then in increasing order are the teaspoon, the tablespoon, and the cup. The use of the teaspoon as a measurement is familiar and widely practiced by many. If strictly accurate dosing is needed, it's important to convert to a metric equivalent. Such conversions are done by memorizing equivalents and then calculating conversions. And you guys will get exposed to this on several levels as you complete your assignments in your Dosage 360 calculation assignments. So although a ratio, proportion, or formula method of dosage may be used, the dimensional analysis methods removes the need for multiple step calculations and is a consistent method for calculating medication dosages. Everyone has their own system of doing this, and that is fine as long as you come up with the correct answer, and that's the most important, which, you know, I use ratios, I have and I need, and then I set it up as a proportion and move across. And this both systems are actually included in your Dosage 360, and also there is an assignment that's posted in Canvas that actually shows the work of the dimensional analysis as well as the portion or formula method. So it just doesn't matter what method you choose. It's just important to identify the appropriate medication and the appropriate dose. So the 6 rights of medication administration were actually developed as a framework to help nurses prevent mistakes. These need to be embedded in your head, and yes, these do need to be memorized. So the 6 rights of medication administration are the right drug, the right dose, the right time, the right route, the right patient, and the right documentation. And I had mentioned earlier how important it is to understand the right indication. What is this drug being given to this patient for? And is this a medication appropriate for this patient for that condition? The first check consists of verifying that the label of the medication matches the MAR, and performing any dosage calculation and checking the expiration date on the medication. So you're always going to take that medication and you're going to verify that with the medication administration. And I had mentioned earlier that it's also important to note the actual order that was given. Just because it's electronic doesn't mean that it was transcribed right or carried over correctly, or that someone didn't miss something, or maybe pharmacy missed something. So these checks are very important. There's 3 checks, and the second check consists of preparing the medication and again checking the medication label against the MAR again after you have your medication out and you're ready to give it. The third check is a recheck of the label on the medication before returning the medication to its storage place, or a recheck of the medication label at a final time against the MAR just before opening the package at the bedside. So you have 3 distinct checks where all of these things should be evaluated. Do realize that a patient does have the right to refuse a medication, and they also have a right to know what the medication is, why it's being given, and educating them on what the outcome of this medication is supposed to do, as well as keeping them abreast of what some of the adverse side effects and contraindications could be of this medication so that they are aware. I also don't want you to think that just because all the 5 rights are followed or 6 rights doesn't mean that a medication error can't be made. Okay, that's kind of a farce. So like I'd mentioned before, to err is human. We do make errors, but these checks and these frameworks, if followed, okay, can certainly help prevent medication errors. The checklist for the safety measures with all medications, there's a checklist that you need to be very, very familiar with. And I have posted those on the Canvas, as well as a link to those checklists, as well as to the videos of medication administration. So I need to ensure that you guys go in there and look at these videos and look at these checklists, print them out if you need to, and become very familiar with them. You will go over this over and over and over all through your nursing, this nursing program, as well as when you're a professional and you're out delivering medications to patients. So the 6 medication rights of administration include, like I said, the right dose, the right time, the right route, right patient, and documentation, okay? Never administer a medication that you did not prepare, okay? This task cannot be delegated even to other professionals. So if somebody walks up to you and says, go give this to room 232, bed A, okay, that's a no-no. You're just gonna have to refuse that. And I don't care how much you trust them, it's not personal. It's that's your license and you earned it. So I would just guard it with your life. Unlicensed assistive personnel, which is oftentimes abbreviated UAP, which I'm sure you've seen in the book several times, they cannot administer medications unless they're in a state that allows designation of them to do that. And typically they have to, your CNAs and stuff, they have to get, take special additional education to administer medications. So it, and it also depends on the facilities, not only the state. But these technicians, okay, may administer certain types of medications. Maybe it's just oral medications. I know that for me, as a hospital corpsman, I could give all the medications except for IV medications. So it just depends. I have stressed this once before, I'm going to stress it again, that if there's ever any questions regarding that medication order, okay, or you don't understand it at all, or something is not making sense, then you need to, it's your responsibility to contact that primary provider or the pharmacist for clarification and seek that clarification. Additionally, don't ever leave medication unattended at the bedside, okay? And this is especially true of your narcotics, okay? Because things can happen, things can get lost, and then you can be in a huge world of trouble. And you'll probably be doing paperwork till your eyes bleed. So just make sure that that medication was drawn up by you, it was mixed up by you, it was pulled by you, and it's yours, and you are giving it. Paper charting, okay, may be necessary if the situation is an emergency or the computer system is not operational for some reason. So that is why we have telephone orders or verbal orders in emergency situations where someone might order something stat or to give it immediately in an emergency situation. For example, would be a code. We can't wait and make sure that it's in the computer and is verified by a nurse and then is distributed or dispensed by a pharmacist. So there are situations where some of that has to be compromised. To safely administer medication, okay, the nurse's first thing is to gather patient assessment data, which is information regarding the patient's allergies to the drug and food, and the patient's pregnancy or breastfeeding status is especially critical. As we mentioned earlier, that there are some medications that can be dangerous to a pregnant patient or a female who's breastfeeding. The other thing is, I would say, so we want to verify the patient using 2 patient identifiers. So it would go something like this. Hey, I'm Brad Geckner. I'm going to be taking care of you today. For the record, can you please state your full name and date of birth for me? And if they state all that and is correct, we're good to go. The next question that should automatically come out of your mouth is, are you allergic to anything? Are you allergic to latex, adhesive, shellfish, avocados, bananas, any other medications, herbs, over-the-counter medications, anything? Now, you may get things like, you know, bee stings and whatever not, which is fine, which probably doesn't have anything to do with us giving that patient a medication. However, if they're allergic to something, we need to know about it. So the body's response to some of these medications is monitored over time to establish therapeutic effects or to watch for adverse effects. For example, a respiratory assessment, let's say it's performed prior to the administration of like a bronchodilator, and the patient is experiencing an asthma attack. Okay, this assessment would include a respiratory rate, will auscultate the lungs, will their use of accessory muscles if they're using any of those, and obviously the oxygen saturation levels. And are they on O2, which is oxygen support. The assessment is repeated obviously after we give the medication to ensure that we've achieved the effectiveness that we're looking for. So as you can see, it's kind of a circle that we just keep going around and around with assessment and planning and diagnosis and then interventions and then evaluating those outcomes to make sure that we're doing what we want them to do. So medications may affect temperature, pulse, respirations, and blood pressures. So, for example, the apical pulse for 1 minute is obtained before administering a cardiac med, such as digoxin, for example, which is a cardiac medication that actually slows the heart and increases the contraction of the heart. Because it is common to withhold the administration if the patient's heart rate is less than 60 beats per minute. And along with the apical pulse, we would also assume that there will be some association with the blood pressure that's going to be also monitored before and after, let's say, an antihypertensive is administered. The patient's temperature is measured before and after, like an antipyretic, like Tylenol. And the respiratory rate is measured before the administration of an opiate like morphine or Demerol or any of those, because those will decrease your heart rate, they'll decrease your blood pressure, and they're going to decrease your overall respiratory rate because they are a narcotic that affects your nervous system, which will affect your level of consciousness. The most important steps for a nurse to take when preparing to administer medications is that assessment of the patient and, as we've mentioned earlier, the adherence to the 6 rights of medication administration. So evaluation of the effectiveness of those interventions occurs within the specific time frames that the nurse establishes in the plan. So utilizing the goals and outcomes provides an objective, measurable way to conduct the evaluation. So we're talking about objective data, typically, which are the vital signs and some of the things that we just talked about, as well as subjective data of what the patient is telling us. All those need to be taken into consideration when you are evaluating the effectiveness of your medication treatments. The medication order, it can be handwritten on a patient chart or electronically entered into the medication system, where it is then transcribed onto an electronic health record, which I showed you earlier, or it may also be on the medication administration record. Medications are basically administered through several different routes, and the clinical judgment, acknowledges that special techniques be used for children and elderly individuals to facilitate the medication administration. So back on another slide, previously on part 1, we talked about the very young and the very old. All of those, that continuum of that age, the age span, we realize that certain special considerations are taken in those populations of patients. So drugs administered by this route, the oral medication, are intended to be absorbed in the stomach, like we talked about earlier, and the intestine. So obviously the patient's ability to swallow, their level of consciousness, and gag reflex, as well as any nausea or vomiting, have to be assessed to ensure that the patient can take the medication by that route. And we obviously want to prevent aspiration, so we don't want anything to end up being pulled down into the lungs incidentally. So we just need to take all that into consideration when we're considering the route. If a patient is NPO, which means nothing by mouth, an alternative route has to be used. So that could be IV, it could be IM, it could be topical, it could be some other route other than by mouth. So drinking fluids is important because it ensures that the medication is not lodged in the esophagus somewhere. So it needs to get down to the stomach where it can be absorbed through the mucosa. So if the patient feels that the medication is stuck in their throat, which you may have at some point, not only drinking some more water, but also eating maybe a small amount of soft food, such as oatmeal or a slice of bread, might help the medications move from the esophagus down to the stomach. Special techniques are used for patients who have difficulty swallowing large tablets. Some of the capsules can be opened and the contents added to a small amount of applesauce, for example, or pudding or ice cream. This is pretty typical for your elderly folks when we're trying to get them to take medications. Sometimes we have to get pretty creative. But you also need to make sure that those medications and those tablets and the capsules, if you're going to do that, can be administered by taking them out of the capsule. Again, I told you that enteric coated tablets and certain medications are not to be crushed and delivered in this manner. So if liquid medications are not in a pre-measured package, most of these items nowadays, it comes in what we call a unit dose, which is pretty nice. So if a doctor orders 30 mils of something, it's usually in a pre-measured little cup that's 30 mils. A calibrated syringe or a medication cup is oftentimes used, if that's not the case, to actually measure the prescribed amount. There are some medications that call for a swish and swallow, and the patient swishes the medication back and forth in the mouth several times and then swallows it. This should be the last oral medication that you give in the lineup administered to patients, so that additional use of liquids to swallow the other medications does not rinse the medication from the mucous membranes. The medication is never given from a container with a label that is missing or difficult to read. Unused medication is not returned to a multi-dose container and should not be placed in unlabeled containers. Medication that has changed color or does not stay in solution is discarded. We should always also offer oral hygiene following medications, especially the ones with the unpleasant taste. And medications can be administered by the enteral route, which is through like a G-tube or gastrointestinal tube. And care is taken that the tube is flushed before and after the medication with about 30 to 45 mils of water, or in accordance to whatever the facility policy is, and that's just to clear the tube of the medication and prevent any clogging that can occur. Also, having the patient sit as upright as possible decreases the risk of aspiration, so we might want to raise the head of the bed 30 degrees and have them remain in that position for 30 minutes after administration. This allows for the absorption time for the gastric suction should not be used for 20 to 30 minutes after the administration. So if you administer a medication through that route, you shouldn't be using suction on an NG tube and pulling, you're just going to pull the medication back out. So note that whatever intake is associated with medication administration, whether they are drinking it or whether it's going into a G-tube, that fluid needs to be accounted on their intake and output record. So the sublingual and the buccal routes, that probably allows for the most rapid absorption of medications such as nitroglycerin, which I had mentioned before. And the patient should not eat or drink anything until the medication is completely dissolved. For the buccal route, patients are taught to alternate cheeks from one side to the other if they're receiving more than one dose. And again, buccal medications and sublingual medications should never be chewed, they should not be swallowed, nor should they be taken with any fluids. Drugs applied directly to the skin for a local effect, and those include lotions, creams, and powders, and aerosol sprays. A gauze dressing may be applied over the medication to prevent removal of the medication by clothing. And I had mentioned to you about nitroglycerin paste, and that would be an example of that. So to reiterate, it's important that you always follow the 6 rights of medication administration. Medications are applied to the skin for many different reasons. Some reasons include treatment of hormones, administration of cardiac medications, which would be the NitroPaste that I talked about earlier, and application of narcotic analgesics like lidocaine patches and topical lidocaine, assistance with overcoming nicotine addiction, that would be like a nicotine patch, and then the treatment of pruritus, provision of a protective skin coating, and treatment or prevention of infection, which is like your bacitracin and your triple antibiotic ointment that we put on all of our cuts and burns and abrasions. Types of topical medications include creams or oils, lotions, powders, drying surface moisture, and other ointments that provide prolonged contact with the medication and to soften, and transdermal patches or discs for continuous medication administration for several hours. Absorption of the medication through the skin is called enunciation, and many patches have an aluminum backing that can cause second-degree burns with defibrillation. So if you're going to be shocking a patient, you should have all those removed. If removal is not possible, it is necessary to check the patient after the event for any patches and treat accordingly. But if you see a patch and it has aluminum on it, it should come off prior to defibrillating somebody. Ophthalmic medications include eye drops and ointments, and each patient has an individual bottle of eye medication, and care is taken to make sure not touch the tip of the drop or the tube to the patient's eye, because infection can occur between one patient and another. So an eye drop should be assigned to that patient and that patient only. So they shouldn't be used as multi-drop going from one patient to another. Again, you're going to keep hearing this, to follow the 6 rights of medication administration. That's very important. The cornea is very sensitive, so most of the eye medications are placed inside the lower lid. Types of ophthalmic medications include eye drops for treatment of eye diseases like glaucomas and some of the other irritations that occur. Ointments, those are typically used for infections or irritations. So for the medications that go into the ear, it's important to use the ear drops at room temperature to prevent nausea, pain, and dizziness. So if they're cold or too hot, they can cause irritation to the tympanic membrane and cause all of that. Medication should not be forced into the ear canal, since forcing it can also rupture the tympanic membrane, which we don't want to do. And of note, I want to let you guys know that all of this is in your book towards the back, where they start to discuss all of the different medication administration routes. And it's just a review of the nursing care guidelines for each one of the routes. So I encourage you to spend some time on all the different routes. Medications are placed in the ear to soften the earwax, destroy insects or organisms inside the ear, relieve pain. If you have children and you know that they have earache, we put drops in there and put a cotton ball in there and have them lay with that ear up. Nasal medications are administered also by the drop or nebulizer formulations into the nose, and the nurse uses medical asepsis when administering nasal preparations because of the connection of the nose to the sinuses. So, and we all know about like Afrin and some of the other decongestant sprays that are administered and squirted into the nose. And when some of those medications are used in excess, they can have a systemic effect, such as the increased heart rate and a rebound effect that increases that congestion. Nasal medications are used to treat things like allergies, sinus infections, nasal congestion, and inflammation. Chronic use, like I just said, of these decongestions can lead to a rebound effect, which basically pretty soon as you come off of it, even though after you took it your nose felt clear and your sinuses felt great, as you come off of it you'll feel really congested again. So, and that's of course only when you use it in excess. We talked about metered dosed inhalers in the last lecture, and the dry powder inhalers that are small. They're just like I showed you the picture of the little handheld device. And there's a skill in your book, 35-2, which describes that. And it talks about the spacer and the bronchodilation that we're seeking, and rinsing of the mouth and the oral care should be performed by the patient receiving steroids by inhalation. This prevents the irritation to the oral mucosa and the tongue and prevents oral fungus infections. And again, assessments before and after all these medications are always done. Vaginal medications are used for infection, itching, antibacterial preparations prior to surgery, contraception, or induction of labor in women after the fetus dies early in pregnancy. Tampons should not be used after vaginal medication installation because the tampon can obviously absorb the medication, and then we're not going to get the desired effect. Rectal suppositories, we talked about those also previously. They're typically thinner than vaginal suppositories, and we use those for a laxative effect, and the suppository needs to usually remain in the rectal valve for 30 to 45 minutes or until the patient feels the urge to defecate. An enema solution can also be used to treat patients with high potassium levels or to rid the bowel of stool before a procedure. Small volume enemas contain approximately 100 mils of fluid and need to be retained for a minimum of 5 minutes, and preferably longer if they can hold it. Large volume enemas contain up to 1,000 milliliters of fluid and need to be retained as long as possible for maximum effect. Transdermal medications are also available in the form of a patch, and previously placed patches and any remaining medication are removed. And I talked about that in the previous lecture about nitroglycerin paste is one of those that come to mind. Parental medications, there are 4 different types, and this is where we're getting into the meat and potatoes of you guys being able to give IM injections and intradermal injections, as well as subcutaneous injections. It's important to note that when we're doing IM injections or IV or any of that, that aseptic technique is used as the protective skin barrier is bypassed by this route. So we need to realize that we're going directly into the muscle, we're going directly into the fatty tissue, and we break that protective skin barrier. So we are bypassing that. So we need to make sure that we're not introducing any microorganisms into the tissue or the muscles or the blood vessels. So various supplies are needed to administer a parental medication, and this is noted in the book in figure 35-7. And the plunger fits within the barrel, and I have a picture that's coming up, but the plunger fits within the barrel, and moving the plunger in and out of the barrel allows for the fluid or the air to move in or out of the syringe. With what we call a Luer lock syringe, the needle is secured onto the end of the syringe with a twisting motion. And there are other syringes that have needles that slide onto the end, and there are others that come that are already preloaded with a needle on it. So a non-sterile object should not touch the tip of the barrel or the inside of the barrel or the shaft of the plunger or the needle. So keeping all of that in mind, that's why we say aseptic technique has to be maintained, because if it touches any of those other surfaces, then we've contaminated, and we don't want to introduce microorganisms into the patient. As mentioned before, syringes range in a different range of sizes from a 0.5 milliliter, and that's typically your intradermal, and then your subcutaneous injections, which can go up to like a 60 milliliter syringe for irrigations and tube feedings. On figure 35, TAC 8, it goes all over those types of syringes. But the three common types of syringes are your standard, your tuberculin, and your insulin. Here's that picture of a syringe. So just note the different parts of the syringe. And most of you who have decided to undertake nursing have looked at a syringe before, and now you just know all the fancy parts for it. So, and here are a picture of some of the different needles. Most needles are made of stainless steel, and the hub of the needle fits into the tip of the syringe, and the shaft of the needle is metal. And the bevel is the slanted tip of the needle, which when we're given injections, we make sure that the bevel is up, especially when you're giving an intradermal injection for, like, say, a TB test or something like that. The bevel has to be up, and that's also true when we're starting IVs. The bevel has to be up. As the gauge number decreases, as you can see here, the diameter of the needle increases. So the common gauges range anywhere from an 18 to a 30, with larger gauges such as a 16 or even a 14 used in emergency departments or operating rooms. In the operating room, we put the biggest needle or the biggest IV that we could get in, because we're going to be pushing a lot of fluid and a lot of medicine through it. Long-acting medications formulated in an oil base for sustained release require obviously a larger gauge needle because of the viscosity of the medication. So the proper needle length depends on the age and the size of the patient and the route of administration. Shorter needles are used for children and thin adults. And those are just general guidelines. Medications can also be prepared from ampules, or what we call vials, and it can come in a powder form that needs to be reconstituted, which I mentioned before, and that skill is in your book 35 TAC 3. The ampules, the glass ampules, can range in size from 1 milliliter to 10 milliliter or larger, but all have a constricted neck, as you can see right here. And that is the area where you grab down here with the alcohol pad and up here with the alcohol pad, and you snap it off. And a colored ring around the neck usually identifies where the glass is pre-scored, and that's probably where it's going to break. The ampule neck is cleansed with an alcohol wipe. A protective sleeve or a sterile 2x2 gauze is used when breaking the ampule. Top to protect the nurse from getting cut by the glass. And after the needed dose of medication has been drawn up, and that is done with a filter needle, as I had mentioned before, so we prevent any shards from getting up into the syringe and being administered to the patient. So filter needles are important for that, especially if, typically only if it's glass. If it's in a bottle like this, a plastic bottle, obviously there would be no need for a filter needle. But after we remove the lid, okay, we would swab the top of that with alcohol, and then we would draw up our medication, and then again, you would remove that needle and put on the needle that is required for the route of administration you are delivering. So a vial, on the other hand, versus an ampule, has a self-sealing rubber seal at the top, like what I just showed you, and there'll be a picture coming up. And then there's usually a soft metal or a plastic cap that is easily removed to access the rubber seal. So a needle attached to the syringe is used to pierce the rubber seal, and then the proper amount of fluid is drawn into the syringe, and then alternatively, an adapter for use with a needleless cannula may be used if multiple doses are to be drawn from the vial. If more than one dose is to be used from a multi-dose vial, which means it has multiple doses of the medication in there, the vial has to be labeled with the date and the time that it is opened, and the initials of the nurse opening it. and then the medication is either used or discarded when the designated time to protect from possible microbial growth within the vial. And typically that is 28 days from the time that you open it, and it depends on the manufacturer and it depends on your hospital policy. I personally, if I picked up a multi-dose vial and none of that information is on there, I am not using it. So just keep your eyes open. If it isn't, then I would just throw it away, because I don't know who opened it, I don't know when it was opened, and I can't guarantee the sterility of the medication. I mentioned that the rubber seal on the top, that is scrubbed with alcohol each time the vial is accessed. So if it's a multi-dose vial, each time you draw out of it, you scrub the top of the rubber seal for 20 to 30 seconds. The vial is a closed system, so, and air equivalent to the amount of liquid to be withdrawn is injected into the vial. So if you're going to draw up 10 mils of something or 2 mils of something, you should put 2 mils of air into there before you pull it out. If people don't do that, eventually it forms a little vacuum in there, and then you're not going to be able to withdraw the medication. Now, powdered medications that are in some of these are carefully reconstituted by adding only the proper amount of the diluent identified by the manufacturer, and that will be noted typically on the label or in a medication insert. But you want to make sure that you use only the type of fluid that is required, so that you have the proper dosing, because at the end of the day, when you get done putting that in there, you're going to have a certain concentration of medication per mil or per 2 mils, and that's going to be important for when you're giving your dosage calculations and delivering the medication. Typically, most things are diluted using normal saline and or distilled water, which are pretty common for reconstituting medications. And if you don't know and you don't use medication often, read. Okay, if you make sure you read the directions on the printed vial or the package insert to make sure you know what diluent, what type of diluent, and how much diluent you're going to use. There is a system out there called an Activial system, where there is a medication powder that's actually attached to a rubber stopper on an IV bag, and basically you will, to prepare it, the Activial, the nurse depresses the stopper to combine the diluent and the medication, and then gently mixes the medication. And one of those is Solumedrol, for example, which I'll show you a picture of that here in just a minute. So here are some pictures of what we had just talked about. The Solumedrol is this one right here. So you would push up on this and push down, and it's going to pop this rubber stopper down in here. There'll be powder down here and the fluid's up here. So as soon as you press that down, the fluid up here goes down into here. These are some examples of vials. And those are the glass vials, and then these all up here are typically multi-dose vials right here. And then we also have some syringes that already come pre-filled. And in some institutions, whether it be Solumedrol or antibiotic or something, it may come up from the pharmacy in a pre-filled syringe and already mixed. Depends on your facility. We talked quite a bit about the needleless system, and this is an example of that. This is called an alligator clip, and this basically gets pushed down here, and this plastic trochanter ends up going into this rubber stopper. And now, most of the time, this system is slowly going away. And most things are made to where they directly hook up to here by putting that on there and spinning and turning it on. And when we go over IVs, you'll learn all this, and some of this will probably make more sense. We talked about a filter needle, And as you can see, just make sure and read. It says right there that it's a filter needle, and you're going to need that anytime that you use an ampule. So we're talking about intradermal and subcutaneous and IM injections, and this is a picture, and it's in your book as well, that basically shows the different angles that you're going to use to access the different routes. So for an intramuscular injection, you're going to go in directly at a 90-degree angle, and you're going to use a darting action, and you're going to go hard and fast to the hub, and then you're going to inject it. Subcutaneous, on the other hand, see, we're trying to get into the subcutaneous tissue here, so the angle needs to be more shallow, so it would be about a 45-degree angle. If there are some needles that are obviously short, like a 5/8, and some of your insulin that have pre-filled syringes and whatnot, they have a very small needle on them, so there's no need to go in at the 45. You go in at a 90. It depends on the needle that you're using and the type of patient that you're giving it to. And then the intradermal is very, very shallow, and I mentioned before, it's very similar to like what we do for a TB test, where they inject just intradermally, and it makes what we call a little bleb, and that little bleb is a little raised part where the solution is in there. So for the intradermal, usually a 1 milliliter tuberculin syringe with a very small needle, like a 25 to a 27 gauge needle, and then a 1/4 to a 5/8 inch needle is used to provide the accurate measurement of a small dose. And we also are aiming for a shallow penetration through the dermis layer of the skin. So the smaller the better, and if you do have to use a larger needle, then you will have to go in at a 45. Okay, otherwise you're going to end up in the intramuscular area, and that is the wrong route. So pressure can be applied to the site if needed, but they should never be massaged or any of that sort of thing. And the location of that intradermal injection, like with the TB, is typically documented, and has to be documented on where it was given, so that when we go back to check it, especially for like a TB, I can't think of hardly any other medications that we give intradermally other than the tuberculin test that we do, the TB test. And the common sites for these are the inner forearm and the upper arm and the scapula, and I have a picture of that coming up. So because the subcutaneous area is less vascular, injection into the blood vessels is very rare. So aspiration, okay, is therefore not required for any subcutaneous medications, nor is aspiration to be done for IM injections either. And when we get into discussing the different sites for intramuscular injections, we'll go over that. But the common sub-Q sites include the abdomen, lateral aspects of the arm and the thigh, and then the scapular area from the back in the upper ventral dorsal gluteal area, right over here. And the injection sites will be rotated to avoid development of hard, painful areas where injections are given. So for a diabetic, for example, some folks may give it to themselves in the abdomen. You have to stay 1 inch away from the umbilicus, and then you want to move around and put it in different places. And some places are more painful than others, and obviously someone can't put them back here by themselves. So most of those sites are right here in the abdomen that you'll see used for those subcutaneous injections. So a 0.5 to a 0.3 milliliter syringe with a 25 to 31 gauge needle is typically used for the subcutaneous injection, and a 3/8 to a 5/8 needle is used. Typically, the nurse pinches approximately 2 inches of tissue between 2 fingers and inserts the needle at a 90-degree angle. And if less tissue is available, the nurse would pinch 1 inch of the tissue and insert the needle at a 45. So if you have someone that's maybe very cachectic and very skinny and does not have a lot of fatty tissue, that's where that particular technique would be used. We talked about the age of patients, and a child obviously can require a shorter needle, whereas an obese patient may require a longer one to get to the adipose. The angle of the insertion for the needle is 45 to 90 degrees depending on the weight of the patient. So that 45-degree angle can be used to give subcutaneous injections to very thin patients to ensure that the medication is injected deep into the fatty tissue and not the intramuscular area. And I mentioned that a 90-degree angle can be used if the patient has adequate subcutaneous tissue and the length of the needle is appropriate for that. And typically we say it should be approximately half the depth of the pinched skin fold. And I mentioned that some insulins are supplied in special multi-dose vials, or they're called insulin pins. And these pins are easier for some patients to use at home since the medication doesn't have to be drawn up. It's already in there, and you dial it to the amount of units that you want, and they inject themselves. Intramuscular, we used to, back in the day, give you a shot in what's probably more commonly called your butt, but it was your dorsal gluteal site, which is back on your butt cheek. And there were a couple different techniques that we would use to find the site. Nonetheless, something that is to be talked about here is the need for aspiration. Now, because we used to give it in the dorsal gluteal, which is back on your buttocks, back there are some pretty big vessels as well as your sciatic nerve that are back there. So when we give an IM injection going, using a 1 to 1.5 inch needle, after we would go in, we would aspirate, and we would aspirate looking for blood. So if we got blood in there, then we're in a large vessel and we would have to pull out and redo. So what's occurred over the last 5 years maybe or so, maybe a little bit longer, the only sites that we can use are the ventral gluteal site, the vastus lateralis, and the deltoid. So since these areas are not vascular and don't contain large nerves, there's no need to aspirate. So that is a prime example of evidence-based practice where we took evidence and we looked, how many times do you actually, get blood when you aspirate? Well, it's hardly ever. But if you didn't aspirate, then you were at risk for putting it into a vessel. So if there's no vessels or little vasculature in these 3 sites, why would you aspirate? And their answer is you don't. So you may see nurses in your clinical site still do that, and part of it is probably because it's out of our habit, but there is no need, and the new evidence shows that we don't need that. So that's been a big change in practice. So when preparing to administer these IM injections, we have to consider the volume of fluid being injected. So medications being administered, we have to consider the injection technique and the site selection, the syringe and the needle, which we talked about the sizes and the length of the needles. Injections into the deltoid are limited to 1 mil or less. So sometimes the amount of medication that you're giving is going to also dictate which sites you can. The majority of things you can give in the deltoid, there's enough muscle there for that to occur. And it's also very accessible versus these other 2. And this is probably the second most accessible, which would be your vastus lateralis. And what it's showing here, particularly in these pictures, is how to find those sites. And we will go over that in lab, and we'll be trying to find those sites on each other and get pretty familiar with all of that. It's also crucial that you guys make sure that you watch the videos. There's quite a few of them, and I understand that, but for all the different routes, of medication administration. Each one has a video for it, and it shows you how to find these sites as well. So the primary site for administering an IM injection for smaller kids, which we talk about that different, the age span, for patients over about 7 months old, is the ventrogluteal site, which is right up here. Because again, I mentioned to you that these areas are free of major blood vessels, nerves, and fat, and it's associated with a far lower rate of injury. So after the medication dose is prepared, we mentioned that a new needle is placed on the syringe so that no medication on the outside of the needle is going to irritate the skin. And that's also to say that we don't introduce any microorganisms into the skin, because we are breaking that skin barrier. So a large muscle site, such as the ventrogluteal, is selected. The site is prepped with an antiseptic cleanser, and then the overlying skin and subcutaneous tissue are pulled approximately 2.5 centimeters or 1 inch laterally to the side, and this is called the Z-track. And what that does is, if you can look at this picture, it shows you what happens, and basically it keeps medication from getting out of the injection site and coming out of the skin. So if that technique is needed to keep that medication in there, that's one thing that we can do to prevent that from happening and keep the medication in the site until it's absorbed like it's supposed to be done. So also, when we give these subcutaneous injections after you go in, typically after you inject it, you should wait approximately 10 seconds to allow the medication to come out of the syringe and for medication dispersion into the subcutaneous tissue. And then the needle is drawn straight back the way it went in, and the skin is immediately released, and you can see here where the medication stays in. So there are some special, what we call EpiPens, and it's a special device that looks kind of like a large pin, and it consists of a needle and a syringe, and it contains 1 dose of epinephrine. And these are typically used in emergency treatment of a very severe reaction or anaphylaxis caused by allergens, exercise, or unknown triggers, and for patients who are at increased risk for these reactions and people who are allergic to things such as bee stings. And they start to have an anaphylactic reaction. Truly, right? You have difficulty breathing, shortness of breath, and if you don't give this epinephrine, okay, they're going to end up in big trouble. So there are 2 different doses that are available. Okay, there's an adult dose that's it's 0.3 milligrams, and that's for individuals weighing more than 66 pounds, and a junior dose of 0.15 milligrams for individuals weighing 33 to 66 pounds. And the injection site for the patient is in the lateral aspect of the thigh, so that's that vastus lateralis site, which again, like I say, we'll go through this in lab. We're going to have a lot of fun trying to find all these sites on each other. And then these EpiPens are typically stored at room temperature in their plastic tubing to maintain their integrity. So we are not going to spend a lot of time on intravenous. There's a whole nother chapter on that, and we'll learn about IVs and starting IVs and adjusting the pumps and playing with tubings and IV piggybacks, so on and so forth. The disadvantage of the IV route is it's costly. So, and the administration of those medications are typically expensive medications. So maintaining an access to a vein is, it introduces some increased complication risks, and specifically we're talking about infections, extravasation. Extravasation is when a medication goes into the IV and that medication leaks out around the vein into the tissue, and it causes thrombophlebitis and inflammation and death of that tissue. So there are some risks that are inherently part of intravenous medications, but the more sick the people are, the more likely we are to have to use intravenous as a route of medication administration. So it's also important to note that because that medication is released directly into the bloodstream, we have to take care in preparing and administering that medication by the IV route and making sure that we're maintaining that aseptic technique so that we're not introducing microorganisms into the vein. So all of your medications and all of your supplies that are used in IVs are prepared in that sterile manner. And I mentioned to you that nurses are not supposed to be mixing things, what we call compounding. So for safety reasons, okay, almost all of your IV medication solutions will be dispensed from the pharmacy. And if there was an additive to be put in there, they will do that. So education can be directed to the patient or a family member or caregiver. So they are part of our healthcare team. The patient is part of our healthcare team, and we include them. We include the family members with that patient's information as long as it's okay for them and they allow us to disclose that information. So when providing this medication instruction, it's important to prioritize what the patient really needs to know regarding each of the medications that they're taking or the supplements that they're taking. They need to understand those. And oral medications have been administered in the home for quite a long time, as well as long-term transdermal peritoneal dialysis. IV treatments with infusion pumps are now being administered in the home. And this is obviously under the supervision of an interdisciplinary team that can include home health nurses, providers, pharmacists, and caregivers. So adverse effects, as we had talked about, include nausea, skin rash, change in vital signs, and difficulty breathing. So we want to make sure that we're monitoring those before and after we give medications. We talked about labs. They will be required in some instances to monitor those drug levels in the bloodstream, which will help us determine the therapeutic range required for that patient and that condition. Electronic monitoring can reflect outcomes from medication treatment. We talked about the oxygen saturation of the patient after respiratory medication, and we also talked about heart medications and how that can change a heart. So whatever effects that drug can have on these different body systems, those are the areas that need to be monitored carefully. And vital signs are a big part of that. All right, if there are any questions about this lecture, please feel free to email me. I will try to answer anyone's questions. It's going to be crucial, I just want to reiterate one more time, it's going to be crucial that you guys become self-motivated learners, because we are giving these lectures voiceovers because we had to divide and have 2 labs. So it's going to, when you come to school, it's going to be pretty intense, and you might feel a little overwhelmed at first, but we've been through this many times, and we will get you guys through it as well. So, and a lot of this will make more sense as we go through lab and you begin to start to learn these skills. There are also a list of medication administration checklists, which basically goes through and says step 1, step 2, step 3. And when you're practicing these with or your friends or by yourself, okay, just get used to going right down the line, and you'll be just fine. A lot of it will be your tactile ability to do some of this stuff, and that comes with experience. So we will get you through this, and it won't be long, and you'll be given your first IM injection and starting intravenous medication. So Again, if you guys have any questions, please feel free to contact me.